Welcome back, Titans. Today we are talking patient assessment and our primary assessment, XABCDE or ABCDE or even CAB. We're looking specifically at D for disability. We are looking at altered level of consciousness. A lot of the times as clinicians, either in the hospital or the field or wherever you may practice, you may come across a patient that has a syncopal episode, unresponsive, they're in a coma, or they are just altered from their normal mentation. Some of the good questions to ask if you have healthcare providers on scene or if you have a family member: how long has this been going on for? And what is that patient's normal mentation? Unfortunately, all the time, we're not going to have that ability to ask those questions, to somebody that knows that patient. They may be by themselves, and we're just going to have to do an appropriate medical assessment of our patient. First and foremost, we want to start out with medical versus trauma. MOI, NOI. Is this a mechanism of injury or is this a nature of illness? We use the mnemonic AEIOU tips to better help us assess our patient and rule out some of the underlying causes that could be causing our altered level of consciousness. So let's get right into it. So A is for alcohol and acidosis. Obviously, the acidosis could be caused from tachypnea. We're going to put our patient on end-tidal CO2 waveform capnography. We're going to listen to lung sounds. We're going to look at the patient's respiratory rate, all those different things, and see if that's causing it. Alcohol. Alcohol ingestion can make a patient intoxicated and alter their level of consciousness. We want to check and see if they have an odor of alcohol in their breath or if there's an excessive amount of bottles on scene. Maybe the patient admits to you that they've drank an excessive amount of alcohol that day that may be altering their level of consciousness. E is going to be for epilepsy, endocrine, and electrolytes. So we know that epilepsy is a seizure. Obviously, we have a neurological malfunction in the brain. If they're having a seizure, we're going to be able to provide maybe a Versed or a Valium to help them. Or maybe they're in a postictal state following a seizure for 10, 15, 20 minutes that's causing that altered level of consciousness. Endocrine, it could be a thyroid condition. We're going to do general supportive care. And electrolytes, dehydration, renal failure, liver failure. You'll see this on EKG changes with peak T waves. So we're going to be monitoring our patient. Maybe they need normal saline or lactated ringers from the dehydration. Let's rule that out. I is going to be for insulin. This is going to be an acute onset, usually hours. Maybe your patient's diaphoretic, tachycardic, tremors, ataxia. We're going to check our patient's glucose. Maybe if it's low, we're going to give them some glucagon or some D10, D50. Maybe if it's too high, maybe we need to dilute that patient down because they're hyperglycemic and we're going to give them some saline, or maybe your protocol includes insulin. O is going to be for opiates and other drugs. We know that opiate ingestion can cause constricted pupils, decreased LOC, cyanosis. It's a central nervous system depressant. So we're going to be able to maybe give them Narcan if we need to, if they're that bad off, and then any other kind of drug that could alter a patient's level of consciousness. U is going to be for uremia or kidney failure. This is going to be gradual, days to weeks. This can include nausea, vomiting, dysrhythmias, pulmonary edema. All we can do for this patient is make sure we have ensure our oxygen levels are appropriate. We're going to check glucose and maintain their temperature, and hopefully for proper brain functioning. Now getting into tips, still ruling things out. This can be trauma and our patient's temp. Obviously, if we have a significant amount of trauma to a patient, maybe it's a head injury that's causing ICP to go up and cerebral perfusion to go down. Maybe they have some sort of internal bleeding where they're going into shock. Temperature control, hypo and hyperthermia. We're going to remove our patient from the hazardous environment and try to maintain a normal core temperature for that patient. I is for infection. Infection is usually a gradual, slow onset. Going untreated without antibiotics and proper care can lead into sepsis, and then sepsis is a form of distributive shock. So we don't want our patients to go into septic shock. So we are going to provide general supportive care, get them to a hospital. Maybe they need some antibiotics. Getting into P is for poisoning and psych. Maybe our patient has a pre-existing psychological condition that has them altered from time to time, or they're taking a medication that makes them appear to be altered, or poisoning. The biggest thing with poisoning is it can be an acute to gradual onset, hours to days, and it really varies depending on what agent was induced that causes that poisoning. It could be a snake bite or plants or pesticides, a bunch of different things, even pills. Supportive care and maintaining our patients' vital signs and getting them to a hospital for more testing. Finally, we have S. S is a bunch of them. We have shock, stroke, syncope, and subarachnoid hemorrhage. We know that subarachnoid hemorrhage is an acute onset, minutes to hours. It's not like an epidural, but it could be a thunderclap headache, the worst headache they've ever had in their life, and treat it like a stroke or a seizure. A syncopal episode, we have our patients passing out. We have near syncope and syncope, where they feel like they're going to pass out for near syncopal episodes, and then syncope where the actual patient passes out. We have strokes, ischemic and hemorrhagic, ischemic being our clot that's delaying oxygenated blood getting past it, or a hemorrhagic, which is when we have a bleed inside the brain and having a stroke. We want to be able to identify that with our FAST or our FAST-G exam, however your protocol entails. And then finally, shock. There's a bunch of different kinds of shock. We want to be able to identify what kind of shock it is and how best to treat it. Maybe it's fluids, or maybe it's blood products, or maybe it's a pressor agent, any of those things. So AEIOU tips, we've got on this side, we have our alcohol, our epilepsy, insulin, opiates, uremia, and then tips is our trauma and temp, infection, poisoning, and psych, and then all of our S's. So when you're assessing your patient and you're not sure what's causing their altered level of consciousness, it's good to remember AEIOU tips and hopefully rule some of those things out. Hope this helps. See you on the next one.